Hello, I'm Doug Drachman. I'm the chair of the Faculty Development Work Group at the American College of Cardiology and the director of the Cardiology Fellowship Program at the Massachusetts General Hospital.
John McPherson. I'm the program director for internal medicine at Vanderbilt University and also a cardiologist and a member of the Competency Management Committee.
We're here today to record a module with the goal of professional development for engaged learners and teachers. Our module today will focus on the development of competency-based medical education. We're going to set the stage with a framework using a real-life educational scenario as a springboard for discussion regarding competency-based medical education. And John, I'd like to describe this scenario that occurred to me just the other week as I was precepting our fellows clinic at the MGH. A fellow presented a case to me of a 93-year-old woman who was referred for the evaluation of new atrial fibrillation. She's independent, high functioning, has hypertension and a stroke about a year ago, and the fellow turned to me and asked, should I use warfarin or one of the novel oral anticoagulant therapies as we move forward with her care? As I thought about this situation, I considered how best perhaps to standardize our fellows' education with regards to teachings in atrial fibrillation and how we can improve the structure of our fellowship. I thought we might take a moment to share our best practices of competency-based medical education. I wondered if you could describe to me your take on the application of competency-based medical education to real-world scenario, and you give the view from 10,000 feet, and perhaps as we go along, I might pepper the conversation with the detail of how we address this in real time with the patient and fellow scenario that I described.
Absolutely, Doug. So competency-based medical education is really a new way to both view and also design educational activities. With competency-based medical education, the teacher is really focused on the outcomes. In the old traditional educational approach in medical education, it was more centered around the educator. What is it that I think that the learner needs to know? And then I would design a curriculum or a lecture and I would deliver that content to the learner. In competency-based medical education, the initial question should be, what abilities, what does the learner need to be able to do when they're practicing medicine and caring for their patients? And once that's been defined as the outcome, then we can work backwards and design an educational activity. With competency-based medical education, it really is not necessarily time-based. In traditional medical education, they're on a 2-month rotation in the cath lab before they reach a certain level, and then they spend another fixed amount of time with their education. In competency-based education, it's really focused on the achievement of abilities or milestones that really define their progress with education.
That's a great overview. Why don't you take us through this just step by step on how you might set about developing competency-based medical education?
So I think you brought up a great example. This is somebody that, or this patient care scenario I think is something that as cardiologists we all see in our practice. An elderly patient who has atrial fibrillation and we're deciding on whether or not they should receive systemic anticoagulation and then what is the appropriate anticoagulation therapy if the answer is yes. So in this particular scenario, my first question is, what is the desired outcome? And I think in this case it would be the ability for the learner or the resident or the fellow in this particular situation to manage a patient with atrial fibrillation and properly use anticoagulation therapy.
Absolutely. So step one, we're going to kind of work it backwards. We're going to take the view from 10,000 feet and say, what is it we want them to be able to demonstrate and plan backwards from there? And that's, what we did. I sat down with this particular fellow and we looked at the resources that we had available. We actually turned to the Team A anticoagulation website and started using that as our initial resource. What do you think would be the next steps that you might pursue?
So the next step is really to identify what are the skills that learner needs to acquire in order to accomplish that particular outcome. So what do you think the skills are for this particular case?
Yeah, so in this particular case, we tried to identify the gap, if you will. And as I spoke with the fellow about the management of atrial fibrillation, we discussed first that he'd need to stratify the risk of stroke for this particular patient with atrial fibrillation. Second, we need to assess what this individual's specific bleed risk would be.
Right.
And then to create sort of a calculus in our head of what is the risk versus benefit of each of the strategies that might be employed to manage this patient, and ultimately to select the appropriate tailored therapy.
Right. So at this point, once you've identified those skills, then the next step would be to identify potential educational resources that you can utilize to teach those skills.
And so in our case, as we turn to this particular patient in mind, we again used the Team A anticoagulation website, and we used specifically the atrial fibrillation toolkit. Within that toolkit, we found a structure called the SPARC tool, which is the Stroke Prevention and Atrial Fibrillation Risks tool, which calculates and graphically represents the patient-specific stroke risk as well as bleed risk. And using those data, we're able to identify and make an informed decision about the appropriate anticoagulant strategy for this particular patient.
That's great. So at this stage, what I would then consider is developing a competency-based evaluation plan. In other words, how are you going to evaluate the performance of your learner in acquiring these skills?
Yeah, so in this particular case, as we had already discussed the skills that are necessary, we thought through ways of evaluating this particular fellow's performance. And I think that a variety of different methods could apply. In this particular case, there was direct observation. As I was working in the fellow's clinic, I observed the fellow walk through the diagnosis and the appropriate management strategy, and ultimately observed directly the interaction between the fellow and this particular patient. I think in other scenarios, one could use a standardized patient scenario, so it could be a simulation in which the discussion of how best to manage this patient might occur in real time, but not with the patient physically present. And also we use a 360-degree evaluation method, so there might be solicited feedback from the patient themselves or potentially from a referring physician who had interacted with this particular clinician to provide feedback about their performance more in kind of a general subject as opposed to at the point of care as we had elected.
That's excellent. Another possibility is also to simply ask the learner when they present a case to commit to a proposed treatment strategy. And once they've committed and articulated what they want to do, then you can immediately assess what are the gaps in their performance in terms of what they're planning on doing and going from there.
Great. So then in the end, how do you provide the fellow with feedback?
Right, so feedback is really critical in any type of education, but particularly in competency-based education. And when we think about feedback, we think about two types of feedback. We think about formative feedback and summative feedback. And the type of feedback that is most useful in this particular endeavor is formative feedback. And with formative feedback, it's really something that's ongoing, and the feedback is really intended to improve their performance at the point of care. So the feedback should be given as immediately as possible, right after the learner has either performed a task or expressed what they want to do. And it should ideally be very constructive with the intent not to necessarily grade or judge their performance, but to improve their performance going forward. In contrast, summative feedback, which is something that we're traditionally used to, is more of a judgment that should be done either at a discrete point in the middle of a clinical rotation or at the end of an educational rotation in order to provide an overall summary of where that learner is in terms of their performance. So when we think about feedback in competency-based education, it's really the former. It's formative, it's hopefully occurring in real time, it's constructive, and it's highly specific to the task at hand.
That's really great. Thanks a lot, John. So I think in the past several minutes we've gone from the general to the specific, and we've reflected on 5 main points that really correspond to how effectively to develop a competency-based medical education module. First, we talked about working backwards, thinking about the established outcomes. Second, we discussed the identification of the necessary skills demonstrated by the learner. In this case, it was a gap assessment. Third, we discussed how best to access educational resources that are at our disposal. Fourth, we developed a competency-based medical educational plan. And then finally, we provided feedback, ideally at the point of care and also in a summative fashion.
Correct.
So with those 5 key points, I think we've got a great working point here, and hopefully you all who have observed this module will be able to use the same to your advantage. Thank you very much for your attendance at this module.